What makes this particularly intriguing is that the peak areas reflect the amount of those sequences present in the sample with very high precision. So for example, if I repeat the experiment I just showed you and generate these two sequencing products, and at the bottom, if the peak areas are not the same, that's real. And it tells you something about the sample quantitatively in addition to qualitatively. Okay, now this tool, DNA mass spectrometry, has hundreds of applications. And this evening I'm only going to show you one. And that application is to look in the blood of patients with disease for DNA sequences that are abnormal because of the disease. The reason why I'm showing you this example is it's exactly the same problem that you have to solve if you've grown up a bunch of cells from a patient and you're about to put them back. What you want to know is there any heterogeneity? Are some of these cells not what you think? Or are they all what they're supposed to be? So you need the ability in quality control to detect a rare cell where something has gone wrong. So you need very high sensitivity. Now, if I'm going to look in blood for evidence of disease, I have the same problem. Because most of the cells in blood are normal. And if there's disease present, there'll only be a very rare DNA sequence that corresponds to disease. But I'm going to take this one step further now and tell you that in blood, we're not actually looking at the cells. We're looking at free DNA molecules which circulate in the blood. How did they get there? Well, during the course of normal development and also during the course of disease, cells die. And when cells die by a process called apoptosis, programmed cell death, they chop up their DNA into uniform-sized pieces. And those pieces are small, and they get into the blood. So anytime you sample a person's blood, you get a picture of dying cells throughout that patient. And the kind of patients we're going to look at now are patients with cancer. Okay? So I'm going to show you two examples. Here's the first one. It's a very complicated title, lots of technical terms. These are lung cancer patients. And we've learned a great deal about lung cancer in the last 5 years. So we have some brand new drugs which are remarkably effective for people with lung cancer if they happen to have tumors with certain abnormal DNA sequences. And one of the ones which is very favorable to treatment is something called EGFR, epithelial growth factor receptor. And if you have certain mutations in this gene, you become susceptible to some of these new drugs, which are remarkably effective. So that's great news. Okay? And what's done routinely now in the clinic is if you get a lung cancer biopsy, you examine that biopsy for abnormalities in the DNA sequence of this gene. And if you find certain abnormalities, you treat with new drugs that are very effective. The problem is that all cancers have unstable genomes. They have what we formally call a mutated phenotype. Okay? So the genome is changing. And because the genome is changing, what happens is these cancers that you're trying to treat develop resistance mutations, which make the drug ineffective. And at that point, what you want to do is switch drugs, if you have another choice, okay? And one of these famous resistance mutations is called T790M, amino acid threonine changes to methionine in position 790. And this makes patients much less sensitive to these new drugs. Now, if I see this mutation in the biopsy sample, I know not to treat the patient with the EGFR inhibitor. But as I start to treat the patient with the EGFR inhibitor, this mutation may arise. Okay. How do I know? The patient's not going to volunteer to let me biopsy again. Okay. So I have to have a non-invasive way of doing it. And this work, which comes from Japan, describes that. Now the challenge is these mutant cells are very, very rare. So there are a whole bunch of tools, in principle, that allow you to detect a very rare sequence in the presence of a huge excess of common sequencing. But they mostly really don't work well. The trick that does work very well is shown here on a slide which is quite complex, but we're not going to go into the details. I'm interested in detecting that T790M, and you can see that sort of in the middle of the slide. I'm not interested in detecting the wild type. I know the wild type's there. So what I do is design an experiment in which I sequence the mutant DNA if it's there, but I don't even try to sequence the wild type DNA. And what that does is give me about a factor of 100 increase in sensitivity in detecting the mutant DNA. And you can see that if you look over on the right-hand side of this slide, which are just artificial spike-in experiments, and I get a very, very strong peak if I have pure mutant. Still a peak I can see if I have 1% mutant, even a peak I can see if I have 0.3% mutant, but no peak if there's no mutant. Okay. So this was a relatively small study. They looked at 75 patients. And unfortunately, they found this resistance mutation in 28% of them. Okay? So this resistance is very common. But what I'm showing you is a very sensitive tool that allows you to detect it. Now here's the consequences for those patients. Just look on the left. The green curve, if what we're plotting is progression-free survival, how long you can keep the patient on the drug before the lung cancer starts to grow again. And you can see that in green, you might have almost 2.5 years for some of these patients before disease occurs if they don't have this mutation. But you can see the red curve. Unfortunately, these patients, after about 1.25 years, the drug is no longer effective. Okay? So this is just one example, a very simple example, of how by looking at a very rare DNA sequence, in this case in cancer patients, you can make informed clinical decisions. And here's another example that's very similar in flavor. CML, chronic myelogenous leukemia, is a very serious disease. And it's caused by a chromosomal rearrangement. So all of these patients have an abnormal genome. That chromosomal translocation brings together two genes inappropriately, the BCR gene and the Abl kinase. And this abnormal gene product, the protein that results from this chromosomal translocation, causes the disease. This is the root cause of CML. And we have a wonderful drug. The formal name is imatinib, but you probably know it as Gleevec, which is fantastically effective for CML patients. Except, if you treat them with Gleevec, eventually they become resistant to the drug. For the same reason that the lung cancer patients become resistant to EGFR inhibitors. Okay? The leukemia mutates, and eventually the protein product from that fusion doesn't bind the drug. Okay? But in the case of CML, we have two other drugs. And so what you want to do if you're managing a patient is ask, when do mutations occur that tell me that Gleevec is no longer effective? And which of the second-tier drugs should I try next on that patient? You probably know these drugs cost roughly $5,000 a month. So that these decisions are not only life-critical for the patient, but they're very serious for the medical system because the drugs are so expensive. Okay. It is not a simple situation. There are 23 different mutations that can lead to Gleevec resistance. And if I had to measure these one at a time by conventional methods, I'd have to take an unconscionable amount of blood from these patients. Okay? But you can see that we can measure all of these mutations in just 4 small samples. And I've color-coded them to show you that in many cases, but not all cases, having detected some of these mutations, we can make an intelligent choice of drug. All right, now, the challenge is to do this earlier and earlier and have more and more sensitivity. And so we're developing new tricks which further push the threshold. And I'll show you one of these. I'm going to skip that. If you look on the right-hand side, I'm trying to see a rare mutant sequence in the presence of a huge excess of normal sequence. And what we've now developed the ability to do, I won't show you the details, is physically pull that abnormal molecule out of the sample. So we purify it. And if we purify it, of course, our ability to detect it becomes even more sensitive. And here, what I'm looking at is several different rare sequences. On the left top, at a level of 1%, the green arrow is just a control, ignore it. You can see nice sharp peaks, 0.5%, 0.25%, and of course, if I don't have the rare sequences, I don't see anything. So this is remarkably sensitive. Again, I'm interested in using this to spot cancer in patients and make decisions. For regenerative medicine, you should be interested in using this to quality control any cells that you're going to put back in a patient. Now, I want to show you now a problem that fascinates me, and some of us have been talking about it this afternoon. There's no reason if you have a cancer, why all of the cells in that cancer should be the same. There's no reason why they should even be similar. Basically, a tumor is evolving to have a growth advantage over the host. And any combination of cells in that tumor that give it a substantial growth advantage over the host will be selected for by the evolutionary fight between the tumor and the immune system. And there are some wonderful cases here. And this is glioblastoma. It's a brain tumor. It's an awful brain tumor. And glioblastoma has a mutation, once again, in this EGFR gene. But if you look at a sample of the tumor, at things that look like tumor cells, we're not talking normal cells, which also contaminate every tumor, only 5% of the tumor cells have this mutation. And the other 95% do not. And what's going on here is that the cells that have the mutation are actually rather sickly. And they don't grow very well. So to get a fitness advantage, they cooperate with cells that don't have the mutation. And it's the mixture of the two that grow well. Okay?